All right, so we're going to go ahead and get started. First off, thank you everyone so much for joining us today for this webinar. My name is Kimberly Mankis. I am a health educator at the Maxwell and Eleanor Blum Patient and Family Learning Center at Mass General Hospital.
And my name is Mariam Daib. I'm also a health educator here at the Blum Center.
And today's program is a special collaboration between the Blum Center and the Cancer Center here at MGH as well. And before we get started in the presentation, I would like to go over a few things. So please note that this session is being recorded for educational purposes. If you are interested in viewing this recording, it will be made available on the Blum Center website at massgeneral.org/Blum Center, and as well as our Mass General YouTube channel. Everyone is in listen-only mode, so everyone has been muted to eliminate background noise so that we can hear our speaker clearly. If you have a question, please use the chat feature at the bottom of the screen. Only the Blum Center staff, the co-host, and the guest speaker will see your questions. We will have time at the end of the session to do a question and answer session as well. Please don't share any medical personal information or questions in the chat. If you have a medical question, please ask your doctor. And next, I am going to introduce you to Devin Punch. She is the health educator for the Mass General Cancer Center. She's going to introduce you to today's speaker.
Hi, everyone. Welcome. Thank you for joining us today. And thank you, Meredith, for being here. I'll quickly just introduce Meredith, and then I will turn it over to her. Meredith Seidel is a cancer genetic counselor. She earned her master's degree in genetic counseling at Mount Sinai Medical School in 2010 and has been working at the Mass General Center for Cancer Risk Assessment since 2011. Meredith and her colleagues evaluate and counsel individuals regarding the risk of hereditary cancer. They offer a range of clinics focusing on breast and ovarian cancer, GI cancers, prostate cancer, renal cancer, hematologic malignancies, and endocrine and neurological tumors. Thank you, Meredith. I'll turn it over to you now.
Thank you, Devin. And thanks everyone for joining this afternoon. I appreciate the Blum Center for putting on this series. And today, for my part in the series, I'll be talking about your family health portrait and how and why to learn about your family history of cancer and other conditions. Let me just go ahead and share my screen so you all can see my slides. Is that working? Okay, good. So again, my name is Meredith Seidel, and I'm a cancer genetic counselor at Mass General Hospital. My slides aren't advancing. There we go. So just an overview of the topics that I'm going to cover today. Just a brief background on what a genetic counselor is for those of you who have never met with a genetic counselor or are not familiar with the field. Talking, of course, about why family history, health history is valuable and how to go about gathering information for family health history. When should someone be concerned about genetic risk in their family history? And then using some case examples from cancer genetics to illustrate when someone should be concerned about genetic risk. So what is a genetic counselor? We'll start with just a simple definition. Genetic counselors are professionals who have specialized education in genetics and counseling to provide personalized help patients may need as they make decisions about their genetic health. Today, there are about 5,000 certified genetic counselors. And this is a definition that just comes from the National Society of Genetic Counselors website, nsgc.org. 15 of those 5,000 certified genetic counselors are pictured here. These are the genetic counselors in the Center for Cancer Risk Assessment, or the Cancer Genetic Department at Mass General. I should add that there's a 16th individual in this picture as well, who is our genetic counseling assistant, who's invaluable to our team, but she's a very tired, overworked person who supports all 15 of us. So what do we do as genetic counselors? At a higher level, we guide and support patients who are seeking more information about things like inherited diseases and conditions that might affect them or their family members. We think about how family and medical histories may impact the chance of disease or perhaps the recurrence of certain diseases, which genetic tests may or may not be right for individuals, and what those tests may tell someone or equally importantly, what information they may not be able to glean from the results of a genetic test. And overall, genetic counselors, I think, pride themselves on informing patients or arming patients with the information that they need to make the best choices they can about their healthcare decisions, about their conditions, and in many cases about genetic testing. Genetic counselors, like physicians, work in a variety of settings and provide different services. So many, or most, I should say, specialize in one area, one or more area, mostly in a single area. Some of the areas of specialty, the major areas of specialty, include prenatal or preconception genetics. So for women who are pregnant, or for families that are thinking about planning to have children, to understand what their risk may be to pass things along to those children. Pediatric genetics, cancer genetics, which is where I work, cardiovascular genetics. So, in the last decade, I would say there's been a lot of progress in understanding the underlying genetic causes of certain cardiovascular diseases, neurology for patients with diseases of the brain and nervous system. And additionally, some genetic counselors focus on research, either exclusively or often in addition to their clinical practice. So this isn't a complete list of what genetic counselors do, but just to provide a sense of the range. Specifically, what genetic counselors do when we meet with patients is, the bread and butter of genetic counseling really is gathering personal and family history information. So it's almost every genetic counseling session includes as an in-depth conversation about that, and a back and forth with a patient to try to gather as much information about their own history and their family history as possible. And that's the greatest tool we have to use to evaluate the likelihood that there could be a hereditary cause to disease in a certain family. So we explain the risks. We can, talk through risks that are associated with particular diseases and medical management options that exist for those diseases. We review what testing options exist. And at this point in time, there's a dizzying array of testing options available. So sometimes that can be a big part of the conversation. We facilitate decision-making, meaning the choice of a test or the choice not to pursue genetic testing. We often order the genetic testing and then review the results with patients and their families. And generally just support patients and families throughout this whole process, and often beyond if there are follow-up, if there's a need for follow-up for the patient. Just as a refresher for many of you who may not have thought much about this for a long time, and as we move into principles of hereditary, just the definition of what a gene is. So a gene is the basic unit of hereditary. So it's a small segment or section of DNA that provides instructions for a specific trait or function. Certain examples of genetic traits include things like blood type, hair texture, eye color, lactose intolerance. There may be multiple genes that can contribute to a single trait, or there may be a one-to-one correlation between a specific trait and a gene that codes for that trait. You may recall that we each have 2 copies of all of our genes. We get 1 copy from our mother and 1 copy from our father. And of course, genes also influence health. So variations in our genes may increase or decrease the risk for certain diseases. So thinking about that sort of more about the idea of a one-to-one relationship between a gene and a trait, and in this case, the trait being a disease. Monogenic diseases are relatively uncommon diseases that are caused by alterations in a single gene. So some examples include cystic fibrosis, sickle cell anemia, and hereditary cancer predisposition. In these cases, individuals may be at a high risk for that particular disease, anywhere from 25 to 50%. And that risk often depends on the mode of inheritance for the disease. So you may recall back in genetics 101, learning about autosomal, or learning about dominant and recessive inheritance. And really there's not a need to go too far into this, but dominant inheritance in general, there's a risk of 50% risk of passing the disease, and for recessive inheritance, it's 25%. There are also multifactorial diseases. So these are much more common diseases that include many genes working together. So I'm not sure if anyone can see my cursor as I point to things, but these are supposed to be genes in that little pile that almost looks like wrapped candy. So in some cases, 5, 10, 50 genes that are all interacting with one another, working together, and also interacting with the environment. And so multiple factors in the environment, different exposures, lifestyle, healthcare, things like that. And it's the interplay between the genes, this group of genes, and those factors that can increase or that establish someone's risk for multifactorial diseases. So I can't remember if I already said that, but examples would be heart disease, diabetes, dementia. So learning about one's family history can help to determine if, when looking at the family history and conditions that may arise in the family history, if it's likely that there is a monogenic condition that explains the family history, or help determine whether genetic risk factors may be contributing to the overall risk for common diseases. So that, again, heart disease, diabetes, cancer, dementia. Can some of the risk factors, such as diet and exercise, be modified to reduce or modify or adjust someone's risk? And this is just another way to depict that. So in this picture, the scale is sort of balancing all of the contributions to someone's risk, which include genes. So, a set number of genes that are contributing to someone's risk, and then a number of lifestyle factors. And so in a certain scenario, depending on what lifestyle and environmental factors may be at play, someone's risk may be much higher. And while we can't really modify the genetic contribution to risk in these cases, modifying lifestyle and environmental risk factors may significantly reduce someone's risk of developing these diseases. So moving on to gathering family health history information. So this is something that we all agree is important, but not many of us do. So in 2004, the CDC did a survey of about 4,000 people, and the vast majority, about 97% of those people they surveyed, thought that it was important to know their family health history, yet only about 30% of them had ever taken the steps to collect that information from their family members. So what are the barriers? What are the challenges? Clearly, there must be some significant barriers to doing the work of gathering the family history. So what I want to talk through is some, practical ways to help break this down and make it seem more manageable, and to work through what might seem like challenges in gathering this information. One thing that's important to remember is that there's not a one-size-fits-all answer. So every family is different, and what works for one family may not work for another. Some things that someone might be up against in their family are things like cultural norms, whether that has to do with religious beliefs or superstitions that prevent people from wanting to talk about illness and death. There may be sensitive information that people are holding on to that they don't necessarily want other family members to know about, things like children who are adopted or children who were conceived using egg or sperm donors. So it might be frustrating not to be able to get all of the information that you're seeking, but just remember that absolutely any information can be helpful. So I like to use the example of, multiple times that I've been in a session for cancer genetic counseling with a patient who will say to me, I'm adopted and I don't know anything about my biological family, so I have nothing to offer you. I have no useful information. But we're evaluating that person for their risk for hereditary breast cancer, say, and perhaps she's a 65-year-old woman. So that in and of itself, knowing that hereditary breast cancer often happens at much earlier ages, so maybe in the 30s or 40s, and if the person sitting in front of me is in her 60s and hasn't developed breast cancer, well, that in and of itself is useful information. So don't discount any information that you are able to collect. So it may be helpful. So again, just some strategies to think through ways to approach this. It may be helpful to start with a list of all of your close relatives, those who are living as well as those who are deceased. 3 or 4 generations would be a good start. So thinking about any children, parents, grandparents, and just to basically list out children, siblings, nieces and nephews, not, you know, absolutely necessary to go as far as things like distant relatives like great aunts and uncles, but if that information is known, it's certainly better to err on the side of being more comprehensive and including as much information as one has. And then you can fill in your relatives' approximate ages, either ages or years of birth. You can include whether they're deceased, and if they are deceased, note the age that they died, and if you know the cause of death, of course, note that. And then just go about the work of filling in any information that you might already have about your family health history. So thinking about medical issues that you've been made aware of, even if you don't know specifics. So, you know, I know that my cousin had cancer, but I'm not exactly sure what type it was. I have a general sense of what age she was when she was diagnosed. So recording any of that information that you might have, thinking through things like cancer, cardiovascular disease, or heart disease, any sort of learning delays that you may be aware of, vision or hearing loss that occurred at younger ages, infertility or pregnancy loss, or even things that don't necessarily conjure up disease or illness, but things like skin spots or birthmarks that multiple members of a family have had. So anything that you might know of, go ahead and just go and include. And then for anyone who has had medical problems, if you also happen to know any possible risk factors that they may have, that may be relevant, those are good things to jot down as well. So if you know that somebody, you know, was a firefighter or smoked their whole life, et cetera, those might be useful pieces of information that would suggest, you know, the likelihood of something environmental versus something that may be genetic. And then you know, you've done all this hard work to gather information, and now you can, see where there may be gaps in your family history. So looking at some information that you may have, relatives that you have a fairly firm understanding of, and then relatives that perhaps you don't have really any information on. And so how do we fill in those gaps in the family health history? So one good suggestion, and this actually came about at the same time that the CDC did that survey in 2004, or sort of formalizing this suggestion, is just to take advantage of family gatherings. And this is a good thing to keep in mind as we head into the holiday season, although I'm sure holidays will look very different this year than in past years. But in whatever way you may gather, this might be a time to bring up the subject of health history. So, you know, family reunions, other holiday gatherings. And in 2004, the CDC also named Thanksgiving as National Family Health History Day, again, recognizing the value of being around relatives that you may not be around at other times of the year and the opportunity to gather information in those contexts. Incidentally, I also discovered as I was pulling together information for this, that this year, National Family Health History Day and Thanksgiving also fall on National Cake Day. So I just didn't want that one to get overlooked, since I think that's a pretty important holiday that we should all recognize. Okay, so filling in the gaps. You know, some approaches may be, you know, to seek out whoever in the family is known as the family historian. I think in many families, there's a person who everybody turns to who has all the information, whether that's a parent, a grandparent, sister, brother. So, or maybe some other older living relatives that you can talk to who may just, you know, have all the info. Sometimes in families, there are people who have done genealogy research, and undoubtedly, if that's the case, they've pulled together notes and documents that may be helpful, things like death certificates that may be helpful to you. You could consider sending out a survey to family members, whether you do that in writing and by mail, or, you know, more tech-savvy electronic surveys. That can be a way to at least get some information from people. Social media, of course, is a good way to connect with people. And often I think, you know, I find the way that people are connected to more distant relatives. So I've even had people who in a genetic counseling session will pick up their phone and go on Facebook because that's the only way they're connected to a certain cousin and, reach out to that cousin and say, can you remind me what type of cancer your mother had and, how old she was when she was diagnosed. Some tips for how to talk to family members about this, because again, it's sometimes not the easiest subjects to broach, especially depending on, where people are coming from with this information or their comfort in talking about these things. It's definitely good to prepare a list of questions ahead of time before talking to family members, to be sure to explain why you're gathering this information. And I think that explanation is helpful if it includes that this information is not just beneficial to you, it's beneficial to the whole family. So once it's collected, it can be information that benefits everyone. And sort of in that same vein, consider a reciprocal exchange of information. So if you are reaching out to a family member to ask them for information, you can also provide them with information that you have, whether it's about your own personal history or other family members who are closer to you. You can help them fill in some of the gaps of their family tree. So it's mutually beneficial. Of course, you're not going to expect that people will know all the answers to all of your questions. That's fine, as we've already talked about. Any information is helpful. If you come across a person who doesn't want to talk about this at all or isn't willing to talk about a certain topic, of course, respecting that person is certainly a good way to go, respecting their wishes and not really pushing it too hard. And keeping in mind privacy. So, people may be disclosing information to you that they don't want shared with other family members. And so keeping that in mind as you proceed as well. Not necessarily another approach, but one way I think to think about this is, sometimes these conversations can happen a little bit more organically. So if you were to sit down with a family member and look through a photo album or an old cookbook, family cookbook, or some other family keepsake, sometimes the stories that come up as you're looking through these things actually generate useful information, and perhaps keeping in mind that you're looking to collect family history information as you're having these conversations and probing a little bit about, oh yeah, how did Aunt Rita die? And, or gathering information that way. So more details. And I think actually that can help people jog people's memories. If you're, have gone through the list and asked them some questions, but they can't remember certain things, they may start to remember as they think through different memories. One thing that I think is valuable, not only for collecting family history information, but just in general to have is to consider recording these conversations that you have with people, just so that you have it to refer back to. Some sample questions that you might ask would be things like, are there any health problems that you've experienced as a child or you experienced as a child? For example, certain types of allergies or anything as an adult. Was there anything that required treatment or surgery? When and where were your parents and grandparents born? What do you remember about them? Were there any health problems that you were aware of that your parents or grandparents had? Has anyone had problems with pregnancy or childbirth? And do you know what types of problems? Are there any diseases that you think might run in our family? Are there certain habits that you've had that could have affected your health? Things like smoking, sun exposure, etc. Is there anything else you'd like to tell me about your life or concerns about in our family? There are lots of resources out there to help with gathering family history information. So some of them are listed here. Many of them include, so I won't go through all these resources, but many of them include actual tools for collecting the information. So whether it is a printout like this that can help you sort of gather and organize the information and prompt you to this specific information that's helpful to have, like age of diagnosis and things like that. Or in some cases, or there is on the a tool called My Family Health Portrait, and this is on the website of the Office of the Surgeon General, which is basically just a online form that you can use to collect information and also send to family members to put information in. So once you've gone through all this effort to talk to your family members, you may find that you have a more, still maybe not a complete picture of your family tree, but a more complete picture of your family tree, more details that you've filled in. And so how are we going to use that information? What's a good next step? So a good step is to talk to your primary care provider about the information that you've collected. It's possible that looking at just, general family history information, there may be obvious modifications that can be made to either diet or lifestyle or other environmental risk factors that could lower your risk of certain diseases. There may be a need to consider some type of early intervention or screening. Things like colonoscopies beginning, not at age 50, which is when many people begin, but perhaps at 40 because there's a family history of colon polyps or colon cancer. And maybe it may allow your primary care provider to identify things that can be monitored as early warning signs. So either blood tests or biomarkers that may be monitored to, as suggested by your family history. And then your primary care may also, use the information that you've gathered and say that, it may be worthwhile for you to see a genetic counselor based on what's some of the things that have come up in the family history. So if you're concerned about a genetic condition, or if this, or if just after gathering it and not even talking to a physician, you're concerned, you can reach out to a genetic counselor. On that same NSGC website that I mentioned before, there is a directory of genetic counselors, so you can find a local genetic counselor to seek out. It's important to store the information in a safe place and to plan to update it periodically as things change or as you gain more information from family members. So when exactly, based on the information that you've gathered, is it appropriate to be concerned about risk for a genetic condition? So first, I'll just mention that, sort of old adage that when you hear hoofbeats, think first of horses and not zebras. And what this means is that the most obvious solution to, or the most obvious answer to a problem is usually the right answer. So not to start by assuming that it's something that's a less common or answer. So if you hear hoofbeats, you would of course most likely think of horses and not zebras. But in some cases, it may be that it's worth looking to see if it actually is zebras that you're hearing. So the certain red flags that you might find in your family history, thinking about genetic conditions, are clues like a family history of a known or suspected genetic condition, multiple affected family members who, so perhaps you don't know the name of the condition, but you know that certain family members experience particular symptoms, and there are multiple family members that have had the same or related symptoms. That may be a sign of a genetic condition. Earlier ages of diagnosis of certain things than expected. So as I noted before, earlier ages of a cancer diagnosis. A diagnosis in the sex that's less often affected. So if it's something that's traditionally seen in men, but you're finding women in your family are being diagnosed with that particular condition. If you're aware that people have had bilateral cancer, for example, so maybe breast cancer in both breasts or kidney cancer in both kidneys, that's a sign that it's maybe more likely to be genetic or hereditary. If there are diseases that are occurring in the absence of risk factors for those diseases, or after preventative measures have been taken to guard against those diseases and they're still occurring, and maybe a strong underlying genetic reason for that. When multiple family members are born with one or more major malformations or certain types of developmental delays, abnormalities in growth, whether that's overgrowth or children who are smaller stature, things like that. Recurrent pregnancy losses, so 2 or more pregnancy losses. Consanguinity, which means that parents are related, second cousins or closer relatives. And then certain ethnicities that are predisposed to genetic disorders. So switching now to cancer genetics, since that's definitely the area I know best. The red flags for inherited causes of cancer are, again, as I've already mentioned, younger ages of diagnosis. So when we see cancers being diagnosed at ages of, 45 to 50 or younger, that stands out as maybe more likely to be hereditary. When we see multiple family members on the same side of the family who have the same or related types of cancer, so breast and ovarian cancer can go together, things like colon and uterine cancer can go together. So that can be certainly a red flag. When there are multiple generations who are affected with the same or related types of cancers, and when we're seeing uncommon or rare cancers in a family. So, a cancer that always stands out would be male breast cancer, or things like ovarian and pancreatic cancer, which are much less common than breast or colon cancer, stand out in family histories. So I'm going to move into a case example from just to kind of put this in context for you. So just to orient you as to how to look at this diagram. And this is called a pedigree or a family tree. And in this diagram, women are circles and men are squares. So women are represented by circles. This is the patient, or what we call the proband. So the person who is providing all of these details. Her name is Christina. This is a fictional patient. She's 35 years old. She's never had a cancer diagnosis. She has a daughter and a son and a couple siblings, a brother and a sister. Her parents are living in their 60s without cancer. She does have an aunt on dad's side of the family, that shaded circle, who is 70 years old, was diagnosed with breast cancer in her 60s. And then further back, a great aunt on dad's side also, who had a breast cancer diagnosis a little bit later in life, around age 60. And then moving over to her mom's side of the family, there's an uncle who had lung cancer, also in his 60s. He did have a history of smoking. And then her grandfather on mom's side, so her maternal grandfather, had esophageal cancer in his 60s as well. So what we're seeing here is, maybe more common types of cancer, lung cancer and breast cancer, diagnosed at older ages of onset. So not that, 45 or younger that we had talked about. And lots of individuals in the family who either lived into their 70s and 80s or are living in their 70s and 80s and even 60s without developing cancer. So overall, this family history is pretty low risk for an inherited cause of cancer. And if we were meeting with Christina, we wouldn't necessarily recommend genetic testing for inherited cancer predisposition for her. Another case example is Kelly, who's also in her 30s, has never had a cancer diagnosis. But in this case, Kelly's mom was diagnosed with breast cancer at a young age. She was 36 when she was diagnosed. And then also on her mom's side of the family, her grandmother was diagnosed with ovarian cancer, so a less common cancer type, in her 50s. And then her grandmother's sister was diagnosed with breast cancer at age 45. So 2 young breast cancers and an ovarian cancer, which is a cancer that raises a flag because it's less common. And then there's also an association between breast and ovarian cancer. And then on dad's side of the family, nothing really too concerning. A grandmother who had lung cancer at 68 and died at age 70. No other cancers on dad's side of the family. But in this case, just based on mom's family history, this would be what we would consider high risk for an inherited cause of the cancer because of that association between the types of cancer, because of the ages of onset. And we would recommend testing for this family. And a third and final example, this is Hector, who's a 46-year-old male who started colon screening. He started colonoscopies at a young age, it appears, based on the information that's provided here, probably because he had family members who had colon cancer at young ages. And he had all along a good number of precancerous colon polyps. So in his 30s and 40s, and then ultimately a colon cancer diagnosis at age 46, which is a young age for diagnosis. His sister also is 48 and has had multiple colon polyps, precancerous polyps. Not as much information provided about his dad, but his dad also, it appears, has had some colon polyps. And then his dad's sister, his paternal aunt, had colon cancer at a young age as well. So in this case, it certainly would be high risk for an inherited cause of the cancer, and we would recommend genetic testing for Hector. So these are just some references. That's really all I have for today. I again want to just acknowledge my team and thank everyone, especially one of these 16, Margaret Emmett, who gave this presentation last year and put these original slides together that I adapted for today's presentation. I've also included the contact information for the Center for Cancer Risk Assessment on here for anyone who may be interested. And I also just wanted to mention that there's one more lecture in this series happening next Tuesday, the 20th, about specific to hereditary breast cancer. And I'm happy to take any questions that may have come in.
Thank you, Meredith, so much. Very informative presentation and very helpful steps, tips for people to start to gather that information. So if anyone has any questions, anything you'd like to ask, can put it in the chat box now. And thank you for including, Meredith, the contact information for for your center. I can also send through the chat box the website, the link for the website on the Cancer Center page.
Great.
So it looks like a couple questions coming in. I met with a genetic counselor in the past, and I was told that my family and I were not at high risk for certain genetic conditions. However, that was over 5 years ago. Should I contact them with updates on my family history if things have changed?
Yeah, absolutely. I mean, we would always think of a family history as being a living document. Of course, things are going to change. People are going to be diagnosed with things. People are going to pass away, and all that information would be useful to use to perhaps go back and reinterpret someone's risk, as well as, you know, other things that we've discovered along the way. So I think it's always useful to go back and update your family history with a genetic counselor if you've had a consultation in the past. Or, you know, of course, on your own as you're gathering family history, to keep that as a living document and update as you go as well.
Thank you. I've been told by many family members that all the women in our family die young, but I've never been able to get more details, and it's been a little frustrating. Do you have any suggestions on how I can get more information?
Yeah, I would say, you know, I mean, again, that in and of itself is useful information, potentially, you know, certainly information that we wouldn't discount in a family history. I would say that if people don't know any details about, you know, the cause of death at a young age, then, you know, perhaps asking questions like, well, you know, was somebody sick for a long time before they died, or did they die suddenly? So, you know, someone who's sick for a long time may be more suggestive of a disease like cancer versus somebody who dies suddenly. Perhaps it's a congenital a heart disease. So I think, you know, probing a little bit more just about what their life was like. Were they sickly their entire life, or was it something that, you know, came on fast or came out of nowhere? Certain questions like that. And again, just getting people to share stories may, you know, help open the door to some more information that could be helpful.
I'm just sending out, oops, not sending it to everybody, just the link to the Blum page where previous presentations, recordings of those are held. Should a male brother be checked for breast cancer if 3 sisters have had it?
Should a male brother be checked? Is that what the question was?
Yes. Should a male brother be checked if 3 sisters?
Well, so I mean, I think one thing would be a good thing to do would be to evaluate. I don't know if any of those sisters have had genetic testing, but that would be a great place to start. And I think, you know, what a male, I think a male certainly should report that family history to their primary care physician, and they may want to do a clinical chest exam for a male just to monitor for breast cancer. I'm not aware that there's a, you know, significantly, or that it's been studied if there's a much higher risk in the absence of certain genetic mutations. But it's definitely good information for their doctors to have in terms of guiding their care and what they may want to do for screening for that individual.
Thank you. We do have some more time if there are any more questions. I'll just give it one more minute in case anyone thinks of anything.
Sure.
We can just wrap up.
Sounds good.
Well, thank you everyone for joining us today. And thank you once again, Meredith, for this presentation.
My pleasure.
Have a great rest of the day, everyone. Goodbye.
Bye-bye.